Hello everyone, we are talking about anti-cancer drugs. In the past video, we gave you a reasonable background about cancer. We talked about immunobiology of cancer in order to give you some ideas so we can specify this video for anti-cancer drugs. You already have a solid base in some of the concepts and terms we need from the past video. Let's start with classification of anti-cancer drugs. As you can see, we have 8 major classes of anti-cancer drugs. These 4 on the left are considered somewhat old. However, these on the right side are considered more recent. The first class we have is alkylating agents. We will explain it and I'll tell you about its meaning. These are one of the oldest drugs and are still used for this very day. Number 2, we have Antimetabolites family. Number 3, cytotoxic antibiotics. Number 4, we have something called microtubule inhibitors. These are considered somewhat old. Recent drugs are something called hormone antagonists. Then we have more recent drugs like protein kinase inhibitors or tyrosine kinase inhibitors. Then number 7 are newer drugs called monoclonal antibodies. Last thing we have some miscellaneous groups of drugs. It is hard to classify them, so they are reserved for the last. Last thing we have some miscellaneous groups of drugs. It's hard to classify them, so they are reserved for the last. These are families of anti-cancer drugs. We will pick 1 or 2 famous drugs from each family. Of course, we can't talk about each separate family in detail. We can talk about all members. However, we will choose the most well-known among them, which might be a drug or 2. In many families, there are 2 well-known drugs, and if we are lucky, it can be only 1 drug in the family. Before we discuss individual drugs and before we get into details, firstly, I want to summarize the adverse effects of anti-cancer drugs because I want you to understand a certain concept which is the center of so many questions. When we ask students in anti-cancer drugs, we mostly don't deviate from these 2 points. You are asked about either mechanism of action or adverse effects. So allow me to draw your attention to these adverse effects. Adverse effects of anti-cancer drugs are classified into 2 main parts, 2 main groups. First one is called general adverse effects, which occur with most drugs. Examiners won't be interested in this. However, examiners will ask you here in the specific adverse effects. Specific adverse effects are particular for each drug. They occur only with 1 drug and don't occur with any other. That's why examiners will ask you about this group on the contrary of general adverse effects. They won't ask you about it because you can easily guess many of them correctly. For example, first thing we expect is bone marrow toxicity or myelosuppression. 90% or 95% of anti-cancer drugs have this effect. May one drug cause more suppression than the other. However, this is reserved for postgraduate students. Undergraduate students are asked about this. Specific adverse effects. Again, general adverse effects are effects like bone marrow suppression, impaired wound healing. When patients on cancer drugs are having surgeries, their wounds are expected to take more time to heal. Number 3, this is very well-known side effect. We all see photos of cancer patients on the web. They have alopecia. Their hair is lost because hair follicles have rapid cycles, so they are affected by any anti-cancer drug. Number 4, damage to epithelial surface. Many patients on anti-cancer drugs complain of mucosal ulceration in the mouth. This is extremely common side effect and it can occur throughout the whole GIT for the same reasons. Cells of mucous membranes have rapid cycles, so drugs affect cancer cells and other cells like them which are rapidly dividing or rapidly proliferating. Number 5. Most of these drugs are hepatotoxic. They can result in sterility. Not only this, but they also are teratogenic and carcinogenic. So even anti-cancer drugs that are used to treat cancer, these drugs can be carcinogenic themselves because they enter cells and affect DNA function. This will be explained soon. As I told you, in most cases we won't ask you about these effects because these occur with 95% of drugs, and you will notice when we discuss any of these drugs, we will skip these effects. You already know them, so there's no need to repeat. However, with each drug I'll target an effect caused by this drug only, not any other drug, so you should focus on this effect and be prepared for questions asking about it. Let's now look at individual drugs, family by family, and let's begin with drugs called alkylating agents. Although this family is one of the oldest families, it is still used nowadays. First of all, let's see what the members of this family are. Don't freak out of these names, because after we mention so many names, we will pick only one or two of them to explain. What are the members of this family? An old class of drugs called nitrogen mustards, such as melphalan, chloroambucil, and cyclophosphamide. Second class is called nitrosoureas. Remember that this is a chemical classification. Nitrosoureas such as something called carmastine, platinum compounds such as cisplatin and carboplatin, others like busulfan, procarbazine, and many other drugs. I mentioned about 10 or 12 drugs on the board. If you wish, you can always surface the web or read about them in books, because they can be 40 drugs or more. It is such a large family. However, we only need to discuss most well-known members of this family. What are the most famous members of this family? They are only 2 drugs, so keep focused on these 2. Of course, we are talking about cyclophosphamide, which you will hear about in so many places, and the fantastic drug called Cisplatin. Stay focused on these 2. If anyone intends to ask you about this family, 90% of cases, he will ask you about these 2 drugs. But no one ever would ask you to enumerate all of them, because even we don't memorize them all. What does the term alkylating agent mean? This term is the mechanism of action, which can be summarized in exactly 3 words. It means the mechanism of action is DNA cross-linking. So if anyone asks you about the meaning of this term, alkylating agent, you answer with only 3 words. They are the drugs functioning by DNA cross-linking. If you wish to understand what does DNA cross-linking mean, look at this figure. Let's zoom in a little bit so we can have a better view. This is the DNA, and you know something called base pairs, which are 4 nucleotides you know about from high school. You know that there is something called guanine. This is guanine. Guanine binds to cytosine. This is called base pairing. Adenine pairs with thymine. We all know this since high school. This is a rule without an exception. Guanine can never pair with another guanine, or cytosine pair with other cytosine. Why am I telling you this story? Because any alkylating agent can be represented by this molecule with 2 arms. This drug hooks up here, extended one arm in this direction towards guanine, forming a covalent bond with it. Then it extends its other arm in the other direction towards guanine on the other side, forming a covalent bond with it. So this drug has 2 active groups called bifunctional groups. Both of them is active. Like 2 arms binding 2 guanine nucleotides to each other. This attachment process is called DNA cross-linking. Drugs can do this attachment between 2 guanine bases on the 2 strands opposite each other. This is called interstrand. One from here and one from there. The drug can attach 2 guanine bases above each other on the same strand. This is called intrastrand. It hooks up here, extending one arm to this guanine and the other to this guanine. This is what DNA cross-linking means. In such ways, drugs now have hindered DNA, so cell can no longer continue its cell cycle. In the past video, we agreed that any error occurring in the DNA, there are checkpoints monitoring for these errors. So when they find an error like this, Firstly, cell won't be allowed to continue its cell cycle and stop dividing, so you now have stopped cancer. Secondly, cell at this stage can die from this direct damage, not only stop dividing but also die. Now I want to draw your attention to a certain point, that all alkylating agents I mentioned on the board, all of them can do this maneuver in any cell of the body, either cancerous or non-cancerous cells. However, they are affecting rapidly dividing cells than any other, so they target quick cells. Those quick cells can be cancer cells. Sometimes they are GIT epithelium, other times they are hair follicles or bone marrow. These drugs don't care, they will reach any cell they can, affecting its DNA by this cross-linking maneuver, whether they are cancer cells or non-cancer cells. The second thing I want you to know about these drugs, they are called non-cycle specific, so they can attack the cells at any stage of cell cycle. They can enter the cell while the cell is in G1 or S phase or G2 or metaphase or at any stage. They are called non-cycle specific. Now we have explained what does DNA cross-linking mean. This mechanism I told you about is applied to all of these drugs without any exception. From now till the end of days, whenever you hear a drug is alkylating agent, then you know that it extends its two arms between two guanine bases, forming covalent bonds like this. We will discuss cyclophosphamide and cisplatin as representatives of this family. This is cyclophosphamide, that's considered one of the most famous drugs in this field. Not only in this field, but you may encounter this drug in so many topics apart from cancer. First of all, as you can see, cyclophosphamide is known to be the most commonly used alkylating agent. Second point is a very important concept in exams. Cyclophosphamide is a prodrug. Prodrugs are explained in General Pharmacology chapter. We say that prodrug means a drug that is inactive in its original form. It doesn't work. Firstly, it must go to the liver where it's metabolized by cytochrome B450 enzyme, forming a metabolite, which is the active form of the drug. So if you were working in a research lab on some cancer cells in a plate and you applied this drug to these cells, this drug wouldn't work. This drug only works in vivo, inside your body, where it can reach the liver to be metabolized into its active form that has two arms and can bind to guanine bases, resulting in cross-linking. Keep this in mind. Now, what about its uses? It is an anti-cancer used in all types of cancers. Breast cancer is merely an example. However, this drug is a broad-spectrum anti-cancer drug that can be used in nearly all types of cancers. Number 2, you have heard about cyclophosphamide in many areas, especially when it comes to autoimmune diseases, such as rheumatoid arthritis or systemic lupus and so on. Be prepared to hear about cyclophosphamide when it comes to any type of autoimmune attacks. You may ask why it's beneficial in autoimmune diseases, yet the answer is very simple. You already know this drug attaches to DNA hindering the cells. And one of the most cells affected by cyclophosphamide is a group of immune cells called T cells, which form a very important part in the immune system. These cells are one of the most affected cells by this drug. And since T cells are a primary component of autoimmune diseases, then cyclophosphamide can be used in treatment of many immune diseases because it inhibits these T cells. And when cyclophosphamide inhibits these T cells, then I can use it to suppress many immune disorders. Don't forget this. If anyone asks you during oral exams why cyclophosphamide can be used as an anti-cancer and as immunosuppressant, this question can be asked in rheumatoid or autoimmune disorders chapters because cyclophosphamide is always among drugs used to treat such disorders. He may ask you about its mechanism of action. It is an alkylating agent. But why it's used in these autoimmune disorders? Because one of the most affected type of cells by this drug other than cancer cells is T cells, which represents such an important component of autoimmune disorders. Now let's see some of the adverse effects you may encounter during MCQ exams. We agree that most of these drugs produce general side effects such as bone marrow suppression, hepatotoxicity, sterility, carcinogenicity, and all effects we mentioned before. And I told you, examiners don't ask about these general effects because they always target these specific side effects in exam. Cyclophosphamide is known to produce a very specific side effect you won't see with any other drug. It causes something called hemorrhagic cystitis. Hemorrhagic means bleeding, cystitis means urinary bladder related. So patients on cyclophosphamide may experience attacks of hematuria, which means when these patients go to bathroom, they find blood present in their urine. Why does this occur? They say because cyclophosphamide sometimes change into a metabolite. I'll tell you its name, but don't bother with it. No one will ask you about it. It's called acrolein. This acrolein is the one responsible for irritation of the urinary bladder and causing hematuria or hemorrhagic cystitis. Naturally, no one will mention this acrolein, however, they will ask you about this hemorrhagic cystitis. You may see a question like this: which of the following adverse effects is characteristic or linked to cyclophosphamide? Of course, the answer is, needless to say, that all choices are correct. They could be hepatotoxicity, myelosuppression, all of the 5 choices would be correct. However, you must pick this one, hemorrhagic cystitis. It is the most specific. If someone asks you in oral exam whether I can avoid this hemorrhagic cystitis or not, yes, we can avoid this. We have 2 things decreasing this effect. Patients on cyclophosphamide experiencing this hematuria are advised to drink plenty of fluids because these fluids wash this metabolite. Don't bother with its name, we don't care. Second option is to give a drug called sulfhydryl donor. Sulfhydryl means a drug containing SH group. This drug is called N-acetylcysteine. Now I feel embarrassed to remind you of this one because I know if I ask where did you see this acetylcysteine before, this will be a little embarrassing. Because N-acetylcysteine is mentioned only twice in the whole pharmacology book, and this is the 3rd time. You heard once about it when we were discussing cough drugs called mucolytics. I told you then that this acetylcysteine, this SH group, causes fragmentation of mucus glycoproteins, and it can be used in patients with chronic obstructive lung disease. It was also mentioned when we were treating paracetamol toxicity. Paracetamol or Panadol, we said then that someone may swallow so many tablets of this drug causing liver toxicity. Then I told you, if a patient was brought to emergency department due to high doses of paracetamol, you could save them with a drug containing sulfhydryl donor, drug containing SH group, because it replenishes something called glutathione stores. This is a reminder for you because I know you don't remember this and I intend to embarrass you and to bet with you. I can make a bet with you and win this bet. It is impossible to see a drug in pharmacology for the first time. You must have heard of any drug at least twice or 3 times. The least drug among them is mentioned before in 2 chapters at least. Here and there, you can see a drug for the 4th time. And because the one examining you is memorizing pharmacology for about 30 years, so it's very possible for him to give you a question in written exams like this one. Mention 2 uses for the following drugs. A list of 5 or 6 drugs, among them is this one called N-acetylcysteine. Mention 2 uses of it. So, when you study, it's very important to remember if a drug was mentioned before. And don't leave the book before you do. When you remember or revise what you want, then on a side of the paper, you write a reminder about this drug, so you never forget about it. This is the only way you can keep track of all these details in your mind. Now we have explained all about cyclophosphamide, covering all possible questions you may encounter during oral, MCQ, or even written exams. Number 2. From the same family, alkylating agents. Remember, we are still in the same family, alkylating agents. This marvelous drug called Cisplatin From the name, cisplatin is a drug containing platin, and of course, we don't have many drugs containing such rare metals. You may have heard of gold, for example. Where is it present? It's present in some drugs treating rheumatoid. Today we have platin. Where is it present? It's present in a drug named cisplatin, and its brother called carboplatin. I don't care about carboplatin, I only care about cisplatin because it's the original one. Its structure is very simple. It consists of central platinum atom attached to an H group from every side, as you can see. This drug was firstly released in the 50s, and as you know, it hooks up in here, extended one arm to guanine base in here, and the other arm for guanine base on the other side, causing what is known as DNA cross-linking, hindering the DNA. Thus, it's classified as alkylating agent. However, they noticed something important when they tried it on patients. They noticed that this drug is concentrated in kidney tissue, as written in some books. This is not exactly true, because it's not concentrated in kidney tissue but in all genitourinary tissue. So it is concentrated in both kidneys, urinary bladder, ovaries, testes, all the genitourinary tract. No one knows for sure why it does this, however, it is a fact, so memorize it as it is. It's concentrated in this area, so it is mainly used for treatment of testicular and ovarian cancer. Now, if an examiner notices a spark of brilliance in your eyes and tried to test you, he would ask you why this cisplatin is used for treatment of testicular cancer or ovarian cancer. You should say it's because this drug is concentrated in genitourinary tissue. It's concentrated in this area in high concentration. Is this beneficial? Yes, because it enables us to treat these diseases. However, when it comes to drug toxicity, and since it's concentrated in these areas, then it's reasonable that it causes nephrotoxicity. They say that nearly 70%, so of each 10 patients on cisplatin, 7 of them are expected to run into nephrotoxicity, because it is more concentrated in the genitourinary tissue and kidneys. So don't forget about this point because it's a very important and popular MCQ question. Second point, which I like to keep asking my students about, is this sensory hearing loss. Cisplatin is famed for it. Sometimes in many patients, cisplatin is excreted in high concentration into the endolymph of the vestibular apparatus of the inner ear, and it can destroy hair cells. Hair cells are cells responsible for hearing. Strangely enough, it targets only one type of these cells, of these hair cells. Not all of them, but hair cells responsible for high-pitched sounds. So if a patient on cisplatin is experiencing this form of ototoxicity, you will find this patient unable to hear high-pitched sound, screams, or for example, if you are blowing a whistle beside him, he may not hear the whistle. However, he may hear other rough voice in low volume, but high-pitched or very sharp sounds expose his hearing loss. Now, if you are an undergraduate student, it's more than enough for you to know that cisplatin is causing hearing loss. But if you are a postgraduate student, I won't ask you on this. Instead, I would ask you which sound is lost due to cisplatin-induced hearing loss. Is it low-pitched or high-pitched? You would answer low-pitched sound is lost in such case. So please don't forget these two effects and add to them this peripheral neuropathy. Any examiner asking you about cisplatin won't deviate from these points, and since we like to ask about adverse effects, then keep focused on nephrotoxicity. Don't you ever forget about it. It occurs in many patients. Sensory hearing loss, especially high-pitched sounds. Number 3, peripheral neuropathy. Patients on cisplatin have a feeling of something breaking them. They complain of breaking sensation as if needles are piercing my hands throughout the day. This occurs with cisplatin. Now we have finished alkylating agents, so let's shift to the next family called antimetabolites. If someone asks you about the definition of antimetabolites, here it is. These are drugs that interfere with certain metabolic pathways. No need to say more. This is the meaning of antimetabolites. Don't confuse yourself because all of these points are unmistakable. These are drugs that oppose certain metabolic pathway by chance Cancer cells are in need of this pathway. So I intervene with a drug that can inhibit this pathway. Let's see what are these antimetabolites. We have three classifications. We have folic acid antagonists and the very famous drug you keep hearing about, methotrexate. We have another family called purine analogues, which are similar to purines, such as a drug called 6-mercaptopurine. We also have pyrimidine analogues like 5-fluorouracil. You have already seen three drugs. These three are important, but the most important one is this methotrexate. If you don't have much time, then study this one. However, these two might also be in some questions. This photo you see explains the meaning of antimetabolites. Allow me to draw your attention to this photo. Here, as you can see, this is folic acid. Here, this is folic acid. Below it is the drug called methotrexate. You can see they are nearly identical in structure, except for one or two groups like an H2 group or CH3 group. However, the rest of the molecule is nearly the same. During cancer cells multiplication, they consume folic acid, and since these cells are in hurry to divide and have no time to look for things, we know that cancer cells have high proliferation rate. Since these cells are in hurry, then they have no time to check all the details. So these cells need folic acid, and since this drug is similar to folic acid, then it competes with folic acid. These stupid cells take this methotrexate instead of folic acid, then they discover this is a trick. But it's too late now. Their hands are tied. They can no longer distinguish between folic acid and methotrexate. This is what antimetabolites mean. They interfere with a certain metabolic pathway. Let's look here at 6-mercaptopurine. This is adenine, which is one of the 4 amine bases, the 4 well-known nucleotides forming DNA. This is adenine and this is 6-mercaptopurine. Their structure is nearly identical, except for this NH2 group on adenine, which is replaced by this SH group, sulfhydryl group. By the way, compounds containing sulfhydryl group are termed mercapto, so when you see this term mercapto attached to any name, this mercapto means SH. Thus, 6-mercaptopurine means that there is SH group present on carbon atom number 6. That's why the drug is called 6-mercaptopurine. It is the same purine as this one. We only replaced this group with SH group. During cell division on S phase, while the cell is copying its DNA, same scenario occurs again. These hairy cells can distinguish between normal adenine bases and this drug, which is incorporated into cell DNA. Then the cell finds out she had been manipulated and can no longer continue its cycle and dies. Third drug called 5-fluorouracil. Here is the uracil base, one of the basic components of RNA, and here is 5-fluorouracil. Looks exactly like it. It is a uracil base, but we added fluor atom to carbon atom number 5. It is originally uracil. Then we added one fluoride atom to its 5th carbon, so it's called now 5-fluorouracil. Now the same scenario occurs once again. Cells mistake this 5-fluorouracil for normal uracil bases, leading to a mess inside cells. In the end, these three produces the same outcome. Any of these drugs is taken for rapidly dividing cells, whether they are cancerous or not. The outcome is the same. Cell can never continue its cycle in presence of these drugs. We are going to discuss the most well-known members, which are methotrexate and another drug. So we will talk about them both. This is the methotrexate, a drug you will see in so many topics, cancer-related or not. Again, the mechanism of action is that methotrexate is nearly identical to folic acid in structure, so it interferes with folic acid. And how can this be beneficial for us? Any cell in the body needs folic acid for copying its DNA material. There is no cell that can multiply without folic acid whatsoever. Either it was a human cell or prokaryotic cell like bacterial cells, even bacteria needs folic acid. In most cases, we can never form DNA or RNA in absence of folic acid. And since this drug is structurally similar to folic acid, then it interferes with folic acid. This is the mechanism for the second time. You will hear about this drug once as anti-cancer. You can use this drug in most types of cancers. It is beneficial in many types of this disease. It is used for a variety of cancer types. But again, such as cyclophosphamide, this drug can be also used as immunosuppressant in autoimmune disorders like rheumatoid arthritis, systemic lupus, and so on, exactly for the same reason as cyclophosphamide. If someone asks you why can we use methotrexate as an immunosuppressant, tell him because one of the most cell types affected by this drug is T cell or T lymphocyte. The same way they were affected by cyclophosphamide, so we used it in treatment of autoimmune disorders. T cells are also some of the most affected cells by methotrexate. These are its uses. So let's look at the adverse effects. Of course, we won't repeat the general adverse effects again. However, this time, hepatotoxicity caused by this drug is somewhat special. I told you before, most of these drugs cause hepatotoxicity and other general effects we mentioned before. But in methotrexate, this effect is so apparent that before we give methotrexate to any patient, we must firstly measure his liver enzymes. As long as patients are on methotrexate, either it's used for cancer or for autoimmune disorders, you should monitor their liver enzymes levels periodically. Once you see that liver function test or liver transaminases, once they are increased above double their normal value, for example, if we say that the upper limit is 25 units or 40 units, once you see them raised 2 or 3 times higher than the normal range, you can no longer give methotrexate and you have to stop this drug because this means that methotrexate is about to cause severe hepatotoxicity. So keep focused on this point because you might be asked in it. Now for the most specific side effects which methotrexate is most famous for. What are these effects? Any antifolate drug, any drug interacting with folic acid from now till the end of days, as long as you hear folic acid, then this drug must cause megaloblastic anemia, and it can cause mucosal ulcerations. Remember to memorize these two effects with any antifolate drug, especially this one, this megaloblastic anemia. We didn't discuss anemia in blood chapter yet. Once we reach this chapter and explain it in detail, you will understand what does megaloblastic anemia exactly means and why are drugs that interfere with folic acid cause megaloblastic anemia. But this is not our main concern right now. All what matters now is when you hear this word methotrexate, you immediately link it with megaloblastic anemia and hepatotoxicity in your mind. Sometimes examiners ask whether you can avoid this megaloblastic anemia. Is there any way I can have this methotrexate without suffering from megaloblastic anemia? The answer is yes, there is a way for this. This drug causes megaloblastic anemia because it's fighting with folic acid. You can give external folic acid for the patient 5 mg per day to compensate for the effect of this drug. Naturally, you might feel a little bit uneasy about this idea. Many students ask me that if we are going to give patients methotrexate in order to compete with folic acid, then why are you telling us now to give them folic acid? Then why we give them methotrexate in the first place? This drug acts by competing with folic acid, and when I give patients this drug, I should also give them folic acid? Does this make sense? Short answer is yes, it makes all sense. We give them folic acid, but not during the same session, not on the same day. If methotrexate sessions are 1 each week, if the patient is receiving a session of chemotherapy including methotrexate each week, then you have another 6 days to give him folic acid, but not on the same day. Never give patients methotrexate and folic acid on the same day, otherwise you are cancelling the drug effect. So you give this folic acid in days called non-methotrexate days when patients are not on methotrexate. Now examiners know you are a smart student with plenty of information about this drug. This is all we need to know about methotrexate. Now for another member of the same family, we're still discussing antimetabolites. The second drug is called 6-mercaptopurine. Now we understand where did this name came from. This drug 6-mercaptopurine, we discussed its composition in the previous figure, and we knew that this drug is structurally similar to adenine. Here is the adenine in the DNA. Cells take this 6-mercaptopurine instead of adenine. It competes with adenine, so DNA structure becomes messy and cell can no longer divide. This is the mechanism in brief. Let's shift to adverse effects. You already know the general adverse effects. We won't waste our time with it. Bone marrow suppression, hepatotoxicity, all the 7 effects we memorized. I am not asking about them, however, I want 2 effects which occur only with this drug 6-mercaptopurine. First one is something called severe myelosuppression. This is severe bone marrow depression that can kill the patient. Personally, I have seen people died from 6-mercaptopurine. One patient was complaining of something. He received 6-mercaptopurine, then he went through severe bone marrow depression. No one could save this patient. They transferred plenty of blood packs to him, but it didn't save him. This patient had severe bone marrow failure. We will see why this drug causes this effect. Second effect is severe hepatotoxicity, and we will also discuss it. Allow me to draw your attention to this 6-mercaptopurine. This drug is connected with 2 types of enzymes in your body. These 2 enzymes must be working just fine in order to avoid harmful effects of this drug. The first enzyme is called thiopurine S-methyltransferase. This enzyme is so essential for metabolism of 6-mercaptopurine. This enzyme converts the 6-mercaptopurine into non-toxic product. It's protecting you from his dark side. Naturally, this drug has a dark side and it can be very harmful. It can lead to severe bone marrow toxicity. What protects you from this dark side is the enzyme called thiopurine S-methyltransferase. It was found out that among all the population worldwide, from each 300 humans, there is 1 human who doesn't have this enzyme, S-methyltransferase. This is a matter of bad luck for him. He doesn't have this enzyme on the genetic level. So what do you think happens when this human, for any reason, receives this drug 6-mercaptopurine? The enzyme protecting the body from the dark side of this drug is absent. This results in concentration of this drug in the bone marrow, leading to severe myelosuppression. And I told you, we have seen this happen with our own eyes. That's why nowadays they never prescribe this drug unless they firstly measure the level of this enzyme called thiopurine S-methyltransferase. Firstly, measure its level. If you find it within the normal range, give this drug to the patient and don't be afraid. But always keep in mind that among each 300 individuals, there is someone who doesn't have this enzyme, so always keep an eye out for him. Second concept I want to mention is another enzyme that is also related to this drug and called the xanthine oxidase enzyme. This xanthine oxidase enzyme, which has something to do with uric acid formation and was mentioned when we explained gout, back then we knew there is a drug called allopurinol. This allopurinol inhibits this xanthine oxidase enzyme. Through continuous research, scientists found that the xanthine oxidase must be available, otherwise this drug causes hepatotoxicity. Why? Because this enzyme called xanthine oxidase is also one of the enzymes protecting us from the dark side of this drug. Thus, we have 2 enzymes protecting us from this drug, 6-mercaptopurine. If one of them is absent, then the patient is expected to experience severe side effects from this drug. We have explained the first one. Second enzyme called xanthine oxidase. You already know xanthine oxidase is inhibited by a drug called allopurinol used for gout treatment. So if this patient on 6-mercaptopurine is receiving allopurinol for any reason, gout, tumor lysis syndrome or whatever, then avoid this 6-mercaptopurine or at least avoid one of them. You can only choose one of them. If the patient must receive allopurinol, then you can never give him 6-mercaptopurine. If there is no other choice than 6-mercaptopurine and you must give it to the patient, then please don't give him allopurinol, because we need this enzyme called xanthine oxidase. Otherwise, this drug can't be metabolized, leading to collection of this drug, resulting in severe hepatotoxicity, severe myelosuppression, and many of these patients would die. After this, we have the next family called cytotoxic antibiotics. Cyto means cell, toxic means something killing these cells. Originally, this family called cytotoxic antibiotics was merely antibiotics. Scientists were trying to discover new antibiotics in order to kill bacteria. When they tried these drugs, they found that these drugs not only destroy bacteria but also human cells. As a result, these drugs were not used as antibiotics. However, they can be used as cancer treatment. Books about these drugs are mentioning so many different names. I'll only tell you about 3 examples of this family called cytotoxic antibiotics, and only one word for each drug. There is only one word which we ask about regarding this family. I'll tell you this word, but firstly, what are the 3 drugs that I want you to know? A drug called doxorubicin, bleomycin, and a drug called mitomycin C. Memorize these 3 names. The word I want you to know, which you will find in the exam, each of these drugs. Look, I don't care for the mechanism, examiners rarely ask about it. However, each of these drugs is linked to a certain adverse effect, as if it was its trademark. This is why it's not suitable to ask you in anything about these drugs except for their trademarks. For example, doxorubicin, this drug or antibiotic is used for treatment of so many types of cancers. I'll never ask you about this, I'll never ask you about its mechanism. If you say it causes DNA damage, I'll consider this correct, because of course it does. However, I won't forgive you if you neglected to mention this drug is cardiotoxic. I do challenge you to find any question at any source about this doxorubicin other than this. 99% of question is about this word. Which of the following adverse effects is much linked to doxorubicin? Answers must have cardiotoxicity. Sometimes they change it a little bit to be more tricky and deceive you. And mention elevation of keratin kinase instead, or other heart enzymes like keratin phosphokinase. So don't you forget about this and don't let them deceive you. Bleomycin. This bleo syllable should remind you of pulmonary fibrosis. Bleopulmonary fibrosis. This is where you find the questions. Mitomycin C can cause nephrotoxicity. So if you hear mitomycin C, always remember the word nephrotoxicity. We don't care much for the mechanism I told you before, but for each one of these names, you should always remember this word. This is all we need to know about this family. Don't waste your time in it. Now we have finished this video. See you in the next one.